You're watching CTOM TV. Knowledge is power.
Great. So standard treatment for melanoma. It was pretty barbaric quite a few years ago when we started. We would get these stage 4 melanoma patients and they would say to us, hey, you can do the chemotherapy, or, the doctors would say to these patients, you can do the chemotherapy, we can do surgery, but it's really not going to do any good. I suggest you just live out your life. So we had quite a few patients that were given that ultimatum. Chemotherapy just doesn't work for melanoma. The drugs they were using were pretty harsh and we're not getting very good responses. Surgery worked, radiation sort of worked, but the tumors would keep coming back typically. So if you go to the next slide. So the standard treatment today, which was not the same as when we first started, 11 years ago, 12 years ago. In fact, one of our first patients, one of the first few patients we ever had 11 years ago, we had sequenced their tumor with a very basic genetic test at the time and found that this patient had this targeted BRAF V600 mutation, which we'll talk about now. And there was a clinical trial for this patient, and we were able to get them into the clinical trial. And then the doctor talked them out of it and said, no, don't bother. It's not going to do anything. There's nothing for melanoma. So as it so happened, this treatment went on to be one of the best standard of cares. So today it's a standard of care. It's called BRAF inhibitors. So a lot of people with melanoma have what's called the BRAF V600E mutation. And so BRAF is the name of the gene. The mutation is a valine, and that's what the V stands for. So you normally have a valine at your 600 position, and it gets converted into an E, which stands for another amino acids. So the V and the E refer to, or the first letters, well, they're not the first letters, they're the letter designation for one of the amino acids. And so in this particular case, a V at the 600th position gets converted into an E, and that's a mutation that causes this gene to stay active all of the time. It does what's called constitutive signaling. In other words, when it binds onto its partner to tell that partner to activate, it gets stuck there and it can't release, and it constantly signals the cell to grow and divide. So with the knowledge of these BRAF mutations, along came BRAF inhibitors. The first one was vemurafenib, and now we have dabrafenib and encorafenib. One of the interesting things that happened when they started using BRAF inhibitors is they started realizing that something was happening with them. In other words, they get a great response, and then the responses would start diminishing. And then some of these patients would actually start developing a side effect, such as a squamous cell carcinoma, a different type of skin cancer. And what they found out was that this signaling pathway that the BRAF was involved in, it's referred to as the MAP kinase pathway, that it had a bunch of little side chains. In other words, it was functionally redundant. So it was kind of like that, I like to use the analogy of the fair game, the whack-a-mole, where you sit there with a little, mallet, and these moles pop their heads up, and you hit one, and then another one pops up over here, and you hit that one, and you keep hitting them. And so cancer signaling is a bit like that. And so when they targeted the BRAF pathway, it overactivated the MAP kinase pathway. And so they found that if you combine it with another inhibitor called a MEK inhibitor, so a MEK is also another component of the MAP kinase pathway. And so what they did was they found that if you combine the BRAF inhibitor with the MEK inhibitor, not only do these patients get a much longer response, but it actually reduces the side effects. So I believe, don't quote me on this, but if I recall, it was about 20% of patients who had a BRAF inhibitor by itself would get a squamous cell carcinoma. And then when they added a MEK inhibitor, it went down to like about 2%. So significant difference and a reduction in side effects. And that's very counterintuitive. You'd think adding another drug would not reduce the side effects, but it actually does. So now we have the combinations that we use. There's a dabrafenib plus trametinib, which is a MEK inhibitor, vemurafenib, another BRAF inhibitor plus cobimetinib, which is a MEK inhibitor, and then encorafenib plus binimetinib. Now, each one of these is basically a offering from a different drug company. In other words, one drug company came out with the brafenib, another drug came out with vemurafenib, another drug company came out with encorafenib. All three of these drugs, while they do target the BRAF V600 as their main target, they also target other cancer signaling pathways. And so this is something that's really important to understand. When you know what the signaling pathways that are driving your cancer, because it's going to be more than just the BRAF V600E. It may be the main driver, but there's going to be a bunch of passenger mutations that could potentially be drivers at a later point of disease, or that could also cause resistance. You want to know what they are, and therefore, picking dabrafenib over vemurafenib is all about knowing what other signaling pathways you have. So dabrafenib may inhibit certain other genetic pathways that vemurafenib doesn't, and encorafenib may inhibit other pathways that dabrafenib and vemurafenib don't, and vice versa. So each company is making one of these drugs, and they're going to have slightly different profiles. So which drug to use? Well, typically doctors will say, let's try this drug. If that doesn't work, we'll try this drug. If that doesn't work, we'll try this drug. We like to cut to the chase. We like to find out what the molecular markers are of your cancer and then decide which one of those drugs is best for you. So that's just a bit of a prelude to what we're going to be discussing later on in this seminar. So the take-home message, 2 drugs. 2 drugs to limit 2 pathways. Sorry, ding.
No problem. I jumped the gun again.
Okay, so what if you don't have this BRAF V600 mutation? Well, what I should say, what we found, and we've had some very interesting cases with this. So typically, if you don't have a BRAF mutation, then what will happen is you will get now a new treatment. The standard of care is immune therapy, PD-1 inhibitors and CTLA-4 inhibitors.
Thank you for watching CTOME TV. Subscribe below and stay informed.